Hello and welcome back. This is Roger Royce with the 10,000 Startups podcast, where each week we bring you original content from thought leaders on issues of interest in startup law. And we're going to take a little bit of a different direction. This is definitely law. I think it's startup friendly, but it's about a topic that might be a little more specialized, some would say arcane, than some of our others. And that is right to try and what's going on in this country with respect to what some would call experimental medicine, but others would call open science. Our speaker here today, or our guest, I should say, is Joseph Jackson. He's the co-founder of Biotech and Beyond, which is a life sciences incubator and community lab in Carlsbad, California. They help scientists conduct R&D in a low-cost, efficient shared lab space. Joseph is also an angel investor. He's an entrepreneur, but mostly he's an advocate for open science. So thanks for being here today, because I don't think I could have found anybody else in the country that is qualified to talk about what's going on right now, or at least as qualified as you. So before we jump into, we're going to talk about the Montana statute specifically, because that's the first one in the country to implement this. But before we do that, I think a little bit of history might be good. And maybe you could tell us, what is this right to try law? And how does that differ than, some of the other things the FDA allows? Like, I was a recipient of expanded access, compassionate use, and then there's certainly other programs. But tell me about right to try.
All right, sure. Thanks, Roger. Appreciate you having me on today. So, as I understand it, about a decade ago, the right to try movement originated out of a think tank. It was the Goldwater Institute, which is out of Arizona. And they tend to be a little more like right libertarian sort of think tank. And in America, we always talk about the idea of the laboratory of democracy, right? The states, with our federalist sort of system, the states are, in theory, one of the benefits of this is that they can experiment with different social policies, right? And things like legalization of marijuana, of course, obviously also kind of took this route, although there's, a lot of devils in the details on that. And we're still sort of seeing how that has played out as well. And it can take decades sometimes for this process to unfold and really harmonize things where the federal level still doesn't sync up with what the states are trying to do. So about 2015, right, this movement started, and eventually in Trump's first administration, he did pass a federal version of this right to try, which essentially just said that you and your physician, if you were terminally ill or diagnosed with something that did not have any other available approved treatments, you could petition to have access to this, even if it's not FDA approved. Now, there always been this kind of mechanism has sort of existed under like off-label use of drugs, but really this sad kind of thing about the whole right to try is that even if you get approved and have your what's called an IND, or an individual investigational new drug application, which you could do with your physician instigated sort of thing for a trial, or compassionate use expanded access program, you're essentially just at the mercy of whoever manufactures that drug to, out of their good graces, they will consider your petition, and maybe not, but 9 times out of 10, they're not going to just give you a dose of that drug. It's probably already allocated to their phase 3 trial, which would be closed. The enrollment has already closed for that. So really what this draws attention to is how flawed the entire clinical trials process system is now. And that is a product of, after 1962, and they had a major law that overhauled the FDA. We had this kind of huge shift in the history of medicine to, prior to that time, it was actually the norm that clinician investigators were initiating most trials and doing that as a routine practice of medicine. And so many of the biggest breakthroughs we could think of in the history of medicine are kind of doing that model of pioneering medicine. It was before these gigantic phase III studies became the norm, which only big pharma can actually afford to underwrite the costs of that. So if you look at that since the 1970s, and a lot of the initial things like chemotherapy protocols, there's a good book on this I recommend to people called The Death of Cancer that was by the former NCI director Vince DeVito. And he's probably passed by now because he was like 93 when he wrote this book. But he basically said that when he was, I think, Sloan Kettering or Boston Children's, when he developed some of these first chemotherapy protocols, he didn't think it could even be approved or done today under the bureaucratic sort of way that the NCI and NIH have evolved, and the way the FDA is now kind of become, this, you have sort of this gridlock where the FDA and big pharma, in a way, perversely sort of point the finger at each other for being, the reason why some of this stuff isn't done faster. But and I'm not saying it's intentional, but the incentives are in such a way that it makes it so expensive for anyone to do these kind of late stage trials that you end up with this system where only a few people can play, and you only got a few big companies developing these oncology drugs. And it doesn't have to be that way. We can have a different system where a bunch of independent investigators, patients actually are doing this. They're running their own trials in the rare disease community. Because pharma had no reason to invest in that, right? So the idea is, how can we actually get people the doses of these drugs? There's like 600,000 people a year are diagnosed with cancer. So we have kind of this ridiculous self-inflicted wound where they say, well, enrollment in clinical trials is really low. And yet they exclude everyone from being able to participate in one. You have to be just sick enough to meet the inclusion criteria. If you're too early in the disease, you're not sick enough. If you're too sick in late stage, then you can't get it. So it's not configured around actually the needs of patients or really advancing medicine, but around this kind of system that has evolved since 1962, where it's all about these kind of somewhat arbitrarily picked endpoints, which are going to be good enough statistically to get this thing approved. And then it may end up having little to no relationship to the actual impact of the practice of medicine. So this is kind of, a lot of people have observed this and pointed this out, but we've been kind of stuck. So I would say what the problem was, the first iterations of these right to try laws really didn't go far enough in providing a manufacturer an incentive to make the drug available. Of course, Pfizer, Merck, somebody that owns one of these assets doesn't want that drug getting out into the wild and being used in one of these kind of, I call them orthogonal sort of trials that people are running under their own, auspices, because if some adverse event happens, they're afraid their whole trial that they've already got in process will get pulled, right? So you have various ways to try to handle that and compartmentalize it or otherwise segregate the liability. But what I think, ultimately we have to do is just you provide this safe harbor mechanism, which is what the new version of the Minnesota law appears to do. And then you say, physicians or other third parties that want to source an alternative manufacturing supply of this drug or gene or cell therapy can go ahead and do that. Now, big pharma's not really going to like that because, it threatens this idea of this patent monopoly. This is a whole other can of worms discussion that we could have. But another thing to keep in mind is the clinical trial system today is essentially funded through this PDUFA, Prescription Drug User Agreement Act. And that's kind of a gigantic conflict of interest if you think about it. The ones that are, it's no different in a way that, like, if the dairy industry is able to mandate that you've got to drink milk, right? And they're the ones like running the studies on dairy. I mean, people joke about big dairy or big whatever. It's become kind of a meme online now, right? And I'm not saying that there's like this conspiracy where big pharma is consciously manipulating all this. It's just where the incentives eventually lead. And it does not have to be the case. We could have a entirely different kind of public good medicine system or a clinical trial system where lots of different third parties could sponsor their own clinical trials. And that is being proposed around things like drug repurposing, where you've got these old generic drugs. Metformin is one good example. Rapamycin is another one that we, of course, have looked at because I was mentioning earlier around the longevity movement, the anti-aging space. Of course, aging has never been recognized as a disease. So the FDA doesn't accept that as a categorization. So you have to do all these mental gymnastics to try to say, well, let's say it's diabetes, it's obesity, all these other things that they will recognize as a condition, right? So there's other groups that have raised considerable amounts of money to try to do this drug repurposing and run trials where they could show you could have a new label indication for an old drug. But you could also imagine hospital systems and other public health payers doing this, where they say, we will put up a bounty for, to show that a drug will reduce this number of days hospitalization, and that will save our system, $100 million over this amount of time. Things like antibiotics, or we have a crisis of new antibiotics, right? We have drug resistance, but there's maybe this market failure or incentive failure to go and develop new ones because they don't see the profit margin there, right? So can we come together and create new kind of financial instruments to do that? And I believe you can. You could do like, an innovation bond is one kind of term. And people have tried to look at this for things like climate change and carbon credits also where there are issues like this. So I think really that this is the kind of bigger picture to take from this, that we have to rethink some of these fundamental assumptions around how translational medicine now operates. And this could be a really good first step.
Well, let's drill down on that. I mean, I'm looking at the Montana statute, and so thanks for that background. And so specifically talking about right to try. So I'm looking at the act, and it says an act revising the laws related to experimental treatments, providing for licensing of experimental treatment centers, amending the Right to Try Act, establishing a health freedom and access requirement, and establishing an insurance premium support account. So it all sounds pretty good. So what is the Montana law going to do that may be a model for the nation, in fact? How is it changing what's happening now?
Yeah, so specifically it says that anyone that wants to be a provider of these therapies, which might be a drug, a device, gene therapy or cell therapy, if it has phase I data, as how I understand it, means that it already has a trial that has safety data. Now that alone can be quite expensive, actually. So you're essentially able to build off of another company's previously published, work on this asset, and things get abandoned all the time in clinical trials. And a lot of times it may be for no good reason, or it could work in some subpopulation, but usually they're dying, later on phase II. So arguably there's this huge bunch of sort of abandoned therapeutic assets out there, also overseas in other countries, where to me it's bizarre kind of that we don't accept reciprocal sort of approvals from other regulatory agencies. It's weird that everyone in the world looks to the FDA as like it's the ultimate arbiter of everything. But you have things like phage, bacteriophage therapy, in use in decades in places like Russia, but it never really became part of the medicine in the West. Right? So there may be another way to interpret this statute also in Montana that says if it had equivalent safety or certification or accepted as safe in general use in medicine for these decades, then they may not stick to this requirement that it has to have a U.S. phase I data package. This is something I need to investigate further, because I think there would be some other categories that would fall under that. So if you want to, then you can register in the state of Montana, $10,000 initial registration fee, and then $5,000 a year, renewal, annual inspections. Yeah, and you can become a provider who offers one of these uh, types of interventions. And
Plus,
so,
there's an annual allocation of profits, isn't
right.
there?
Yeah. So there's another concern about equity. And this is a big thing that I've looked at and talked with a lot of patients groups. People get immediately defensive about the idea that the rich are going to buy early access or something to these life-saving treatments. Well, in reality, cancer doesn't care. It doesn't discriminate. So if you think about Steve Jobs for all of his resources or whatever, it didn't matter, right? He arguably didn't start early enough. The tragic thing about Steve Jobs could have made a huge difference if he had really been thinking about these systemic structural issues at the time, right? So it doesn't matter if you're Bill Gates or Steve Jobs or whatever, we have to get up the ladder, the technological ladder, so to speak, to where these things that were incurable become curable. And then it benefits everyone else, right? And so the statute in Montana stipulates that you've got to set aside 2% of your profits either to this insurance fund in the state or offer to, Montana citizens get the equivalent, I guess, cash equivalent or value. Let's say if your operation is doing $3 million worth of experimental trials, you allocate this percent in pro bono to Montanans. And I think that would be built into the model anyway, as I think one of my inspirations for getting into this 10 years ago is I read a proposal, a British journalist who had gone through this with his friend who ultimately died of cancer. But he raised a couple $1 million through sort of a crowdfunding campaign to help his friend get access to an oncolytic virus. It's a type of gene therapy strategy that's been proposed for decades where you can use these viruses to go in and explode cancer cells. And this researcher in Sweden had a technology that was stuck like after phase one, and they were trying to do a phase two trial, couldn't raise any money to do the study. So he says, well, we've got thousands of clinicians and investigators, thousands of scientists around the world in that situation where they've taken some study through this phase one thing and they cannot raise money for this valley of death sort of thing is the term from startups, right? So what if you just did private financing of that? And he did the math on it. It says, so there's 40 million millionaires, and now it's more in the work of inflation stuff. So we have like 60 million people that have a net worth of $1 million on Earth. If you just did the math on that, how many people have cancer and what the incidence is, well, there's probably a millionaire that has that type of cancer for any type of indication that you would need to run this phase two study. So instead of doing a few hundred of these big phase three studies each year, and that's all they have, right? Because it's so expensive. It's $100 million or more. Instead, we had thousands or tens of thousands of these, like I'd call them open label, as opposed to, it doesn't have to be like randomized placebo controlled trial. This is sort of another problem fetish in the system that says that's got to be the standard. Actually, no, there's a lot we can do from doing what's called observational trials, observational studies, and you let people go ahead and have access to it. And so his tweak on this proposal was that we do it Robin Hood style, so you're not accused, although he was tongue-in-cheek, called it the plutocratic proposal. So let's go ahead and harness the self-interest of millionaires. And the interesting thing about these biotech medicine is it basically is like a fixed cost to manufacture this amount of doses of the drug. So if we're going to run a pilot study of 10 people, maybe that cost of that is basically $1 million. But as long as someone underwrites that, you could have 8 of the patients getting the dose at cost or almost for free or subsidized. So we could structure it in a way that as long as we're doing like cost plus or something, right? And this is the tragic thing about so many things in medicine, even like CAR T therapy, which I've looked at in extensive detail, right? The first CAR T immunotherapies were done with NIH grants money and back in like 2012 at University of Pennsylvania. And then when Novartis and comes out and they acquire the rights to this, their version of it is like $500,000. And of course, it's all dependent on insurance, whether insurance is going to pay for it or not. So many people who could benefit from it will never get approved by insurance, because insurance
But,
incentive is to
but of course,
basically,
Medicare now covers that, I understand.
yeah, to a degree. But then the other part of that is too, your hospital stay is that could be $1 million for the hospitalization part. So the interesting thing with CAR T now is companies in China and now one in India that I've seen have developed it. They've got a version of the cash price is like $30,000 to do it. Right. So in theory, but in the problem here in the US, even if you give the cell therapy part gratis, if you don't have a good arrangement with the right hospital, the facility fee on that can eat you at $1 million or something. So you almost have to own the hospital or have the thing with the hospital and have cash pricing stuff figured out, because otherwise you'll go in. It's like it's the intensive care part where they're monitoring you for the cytokine storm and all this stuff, and that's going to get billed at crazy rates, and you're hoping you've negotiated that with Medicare or whatever. And if you did not, or it's out of cover, if it's deemed not covered because you're doing the experimental thing, so all the ancillary care in support of that is not eligible for reimbursement.
Yeah, well, you definitely hit kind of the nail on the head here. The
Yeah.
biggest problem with this, if it's experimental, it's going to be expensive and someone has to pay for it. And I see the Montana statute. I kind of see where they're going on this with that 2%.
Yeah. So that's
Well,
ultimately that's a good thing to have in there, but we're going to have to kind of, the business model is going to take tweaking and is really going to come down to the details.
it's evolving, I suppose, a work in process. And on that point, are other states following suit? Do you think they will? Are there other programs
Yeah,
around?
so the one that I just saw immediately after, a couple months later, New Hampshire came out with its thing. And that's kind of funny because they're kind of the libertarian state. That's their whole motto. So it would make sense that New Hampshire would be. And they had some strong patient advocates who'd all, who'd been involved, former legislators who'd had cancer and had gone through this, or family members. So they understand the urgency of this, and that's how they were able to kind of quickly follow suit. So I think again, all positive developments, but my biggest concern is sort of the competency, the capacity to do this. I've been doing bodybuilding and powerlifting for most of my life, right? So I always kind of make analogies to the fitness world, fitness industry. So imagine that you suddenly there had been a ban on like exercise equipment, or private ownership of exercise apparatuses was never allowed for decades. Suddenly a state announces, well, now you could own gym equipment or whatever. That does not mean there would be suddenly a whole bunch of, fitness culture and inexpensive commercial gyms like we have today, where you can get a gym membership for $30 on the low end or $300 at the fancier Equinox fitness clubs, right? And people forget, these things take time, right? Even in the late 80s, it was almost unheard of. It was only Gold's Gym and Arnold. He was one of the first people making this popularized sort of thing. And it took a long time for this to go mainstream, and also to get people to go and work out and learn how to do bodybuilding and all this stuff. So it's kind of like, in many ways, people become delusional and think suddenly now that you removing a barrier is not equal to achieving capacity, achieving the result.
That is a really good analogy, because as I understand it, this whole, the reason gyms became a business is because of the machines, right? Now you could put a lot of machines in a smaller space and charge money for it, and everybody could use it, without so much risk of injury, because you kind of have to know what you're doing with free weights, right? And
that's part of the, that's right. That's Arthur Jones and Nautilus and people back in the late 80s, early 90s. But there are all these convergence of factors that did that. And today the fitness industry is berserk. It's now, of course, online, and all the social media supercharged it around 2010, 2011. And so medicine, is this really difficult field. I recommend to people who are interested in this to read this book called Medical Nemesis by Ivan Illich, who is a 1960s, 70s philosopher of technology, anthropology. And he kind of looks at the history of Western medicine and how these perverse incentives evolve to where it becomes more and more institutionalized and bureaucratized. Yeah. And so, on the one hand, you have the physician who takes the oath, do no harm. My dad's an orthopedic surgeon, so I grew up around all this. but over time, it diverges more and more from the role of healing to this industrialized medicine version, which tends to over regulate in some ways, over prescribe some things, but it basically takes away the patient autonomy because
Right.
you've got permanently institutionalized these roles of the patient and the physician. And then it becomes kind of antagonistic rather than being able to collaborate and cooperate to bring about healing. All these other metrics become the focus, right? And we've seen attempts to challenge this. We've had iterations of this we call open medicine movement. We had all this stuff around quantified self and self-measuring, wearables, wearable computers. And there's been a lot of enthusiasm for this in Silicon Valley. There's all this junk around electronic health records. It's constantly attempted every 10 years or so. It's been just a fiasco time after time. And the last big attempt was like 94 with Clinton's, every 30 years or something, we try to do this.
Right.
Clinton's big push, and then Obama tried to do Obamacare. And we're kind of reaching this crisis point. You would think that COVID would have maybe exposed some of the things, but that seems to have made everything worse than ever, right? So I believe there is a sense among everyone who's observing healthcare economics, and physicians are at all-time high rates of burnout, and all of this, that something is really breaking or about to break.
Yeah. So on the other end of that, though, I know the industrialized medicine and the FDA and the regulatory side. The thing that strikes me about right to try is that we've seen a lot of snake oil salesmen that get into any business whenever there's an opportunity, and it's no different than health. I mean, I've seen that myself. People out selling miracle, monotherapy cancer cures that are just bullshit.
Right.
That's a technical legal term, by the way.
Sure. Yeah.
So what is it in this statute that's going to protect this from the carpetbaggers moving in?
Yeah, no, absolutely. I mean, I think, and this comes up so much with patient groups, and a lot of times I have been to a lot of rare disease conferences and things to try to talk with patient advocates, and some of them get extremely defensive and upset about this. I mean, rightfully so. But I think a lot of times they'll jump to conclusions to think that it means that people are automatically going to be exploited or taken advantage of. And the argument, again, people have this paternalistic sort of impulse, instinct that says we've got to have the FDA to protect the most vulnerable patients, have a terminal condition, from getting taken advantage of, right? But I don't think you can do it in the way that they believe, which through a centralized regulatory entity. I think this has to be devolved and distributed down to more specific kind of state and local level and other reputation systems where you would empower clinicians and patients to be able, again, it's been tried, of course, we famously have Yelp for all this stuff. They've attempted to do versions of like Yelp for medicine, or you rate your doctor and stuff. But I think it's going to need really more specific metrics around this. You can imagine building out a dashboard or a checklist, a metric thing around stem cells therapies, all the things you need to check for and look for around that. Here are the things around immunotherapy, peptide vaccines, and all of this knowledge is out there. It's just scattered, and one country may have really good best practices. We talked about Japan, and your experience going over there, and so they have all of this tacit knowledge and stuff that's maybe not codified, right? And then that stuff never even shows up in an FDA data package either. And actually, this type of data, what we call tacit knowledge, is that's where all the magic happens, and it's really difficult to transfer that. That's why you see companies warring over employees, all the espionage stuff in Silicon Valley now around AI. They're hiring away this employee because that stuff is usually in the head of, we haven't figured out how to put that into an LLM yet, right? So there's not some one easy fix for this. You got to kind of weigh it against the alternative, which is it's not like you're safe as the alternative, because you're dying of this terminal thing is the default thing that's going to happen. So again, it's like the other thing people forget. We're not talking about exposing millions of people who are healthy people to a bunch of experimental stuff. These are people that are already very sick. They're going to make an informed decision and self-select to go into this thing to try something. We're not, so people are not really being consistent about the way they talk about risk. And at the end of the day, like, it comes down to how we handle medical risk, and it's not perfect, but for every other thing that we do in medicine, we primarily look at surgery and how we look at physician performance over time, do evidence-based medicine. And, if there's a problem with this surgeon or the surgical center, that shows up in the data, and eventually you correct that. It's far from perfect. Again, my dad's a hand surgeon, and he had a few nightmare situations where he got sued, and he was, the most meticulous thing. And sometimes there's frivolous lawsuits. Of course, we've weaponized the legal system there against physicians. But so there's a way to find a balance, and I think you do it through torts, and liability that way, but not at the FDA level, which has never really been able to. It's a false sense of risk management, and people assume the FDA proclaims that this is safe. It's actually neither necessary nor sufficient. You still certainly have had plenty of things that got through the FDA, and then decades later, this is why we do what's called post-market surveillance, right? So
we could give you lots of examples of that.
So we actually want to move towards more, just because the FDA signed off on something actually doesn't mean that it's going to be safe for you, because the model of personalized medicine says, we've got to stop this one size fits all thinking. And really, the FDA kind of provides blanket liability coverage for companies in different instances, which may not be what we want. We could be doing things, I believe, through, and there's some legal scholars that have written on this more in the context of surgery. I got to look the guy's name up. I think it was like Richard Epstein or something is the one I'm thinking of. But he's looked at kind of stem cells and why didn't we use a model similar to what we've done for surgery for regulating stem cell procedures, and say, it makes perfect sense to, do the liability that way.
Yeah, I get what you're saying, is that nothing's perfect, everything's a matter of risk, but this gives the choice back to the patient, and maybe we can crowdsource some.
Well, yeah, there's interesting stuff. I don't know if you follow like prediction markets and things like this. Right. So there's all this controversy over poly market and these things. So I think the future of things like this is something like we could say a medical Sherpa, or you could get these expert third parties and you incentivize them and say, all right, you can make a bet and say, of course, people get uncomfortable with this, but you need to align the financial incentives. So let's say I need to decide, should I do this surgery or whatever? I need this, these are the risks. Let me go out and survey 3, quote, professional medical forecaster experts. And they could refer you into the physicians, and you could align it in a way that's like, if it's a good outcome, they get a bonus from that, because it turned out that surgery did really, if they're referring people in, unnecessary surgeries. You see this in things like the bariatric band surgery that was being done for obesity before the semaglutide stuff took most of that business. But a lot of these physicians were so over eager to operate on someone who's not a good candidate for this gastric band thing. Sorry.
Yeah, that's a good.
I've had you do these sort of prediction markets or expert referrals, and you build in kind of a corrective feedback mechanism, so you don't over prescribe and push people who are bad candidates through. But so it's kind of like a medical prediction market. Or anyway, these are a little bit far out, futuristic ideas.
Right. Okay, well, that's a good place, I think, to break. So again, thanks for being here, Joseph. Yeah. So this is Roger Royce with 10,000 Startups. We've been talking about mostly right to try. At least that's where we started. We had a wide-ranging discussion. And again, Montana's new statute, which I believe, is this law now, by the way?
Yes, as of May of 2025, signed by the governor. So it's
okay, signed by the governor of Montana. The new a new act regarding experimental treatments. New Hampshire's got an act. Maybe the rest of the country will follow through. So new pathways in experimental treatments and personalized medicine. So thanks again for being here, Joseph, and thank you, audience. We'll see you all next week.